Hello, and welcome to the PsychCast. I'm Vicki Ellingrod, the Senior Associate Dean at the University of Michigan College of Pharmacy and Section Editor for the Savvy Psychopharmacology column in Current Psychiatry. I am also a member of the College of Psychiatric and Neurologic Pharmacists who partner with Current Psychiatry on the Savvy Psychopharmacology column. Today, I will be the guest host of this episode, which will focus on pharmacogenomic implementation in practice. With me today are Dr. Kristen Ward and Dr. Amy Pasternak, who are both clinical assistant professors at the University of Michigan College of Pharmacy and are leading the University of Michigan's precision health implementation work efforts. Before we get started, I wanted to mention that the topic of pharmacogenomics and mental health and implementation in particular is a very hot topic right now and is actually one we have been covering within the Savvy Psychopharmacology column since about 2016. I'm also happy to report we're going to have another focus of the column coming out very shortly as we have another manuscript that was recently submitted for publication in Current Psychiatry. Therefore, our listeners are looking for, if our listeners are looking for additional information regarding anything that we discussed today or any other perspectives on this topic, they should very definitely check out the Savvy Psychopharmacology column, as well as our other articles that have been published within Current Psychiatry. With that, then, I want to get started with our first question, which I'm going to direct to Dr. Pasternak. If you have one piece of advice that you would want to tell someone thinking about implementing pharmacogenomics into their practice, what would that be?
My primary recommendation for anyone who's thinking about starting pharmacogenetic implementation is to start out by reaching out to those who have already done some work in the area that you're interested in. There are so many groups who have already started developing strategies for integrating pharmacogenomics into their clinical workflows, and there's a lot of opportunities to collaborate and learn from others. And so even though each institution has unique workflows, you may be able to identify some strategies for overcoming common barriers that you share with these other groups and get some inside information on the availability of different testing platforms or guidance on reimbursement strategies or other integration methods.
Thanks for bringing up the idea of insurance reimbursement. We are going to be talking about that in a little bit. I think at this point, it's important to recognize that the readership of Savvy Psychopharmacology is very diverse, or of Current Psychiatry is very diverse. And we are coming at this as people that are at a major academic medical institution. And so we're talking about an institutional adoption of pharmacogenomics in practice, for implementing pharmacogenomics in practice, whereas many of the readers of Current Psychiatry may be in private practice. And so we will try to have some of our responses very specifically talk about how to do this when you're in institutional practice as well as private practice as well. And so I think to your answer, Amy, I think it's really important for people to understand other providers that might be implementing this in practice and some of the pitfalls that they have seen in doing that. I think in finding kind of that group of users that have had successes and learning from them as well, just as we have done here at the University of Michigan in working with other major academic medical centers to determine how best to implement pharmacogenomics in practice. So with that, I'm going to switch to one of the pitfalls that we have kind of determined here in practices, and I've heard from many providers across the country, this is a pitfall or a challenge that they've had when implementing pharmacogenomic testing, realizing that for about 50% of the testing results that come back, there may not be a change in therapy, or some of the results may be inconclusive. So this question is for Dr. Ward. What do you tell a patient if the results come back inconclusive or really indicate that changes to therapy do not need to be made?
Thank you. So I try to frame the discussion with a little bit of a sight towards why the test was ordered. Most oftenly, when I've had the opportunity to be involved in patient care related to pharmacogenetics, they're usually placed for two reasons. So the first is a set of patients where there's not necessarily a plan to change therapy, but the provider and the patient are interested in trying to determine if genetics may have played a role in past side effects or lack of response to medications. So in the other setting, the patient perhaps or the provider wants pharmacogenetic testing completed before trialing an additional medication. In that first scenario, where a change wasn't necessarily planned, when the results come back somewhat inconclusive or there's not a lot of room for medication adjustment based on pharmacogenetics, I use it as an opportunity to talk about genetics only being a piece of the puzzle related to medication response, and then it's really complex. In the second scenario, the discussion is usually pretty similar. And I like to try to use the results to steer back more towards a traditional medication education counseling session, just related to adequate trial duration and dose. Some of our providers do order these tests for fairly somatic patients who have a lot of side effects to even really low doses of medications, and they try to use it as a tool to really encourage adherence and show, like, look, pharmacogenetically, you're expected to tolerate this medication. Let's try going a little longer.
Thank you, Kristen, for that response. I'm going to go back to Dr. Pasternak again and ask, what resources do you recommend for providers beyond finding peers that might also be implementing that would really help them understand pharmacogenomics as well as how to implement this using an evidence-based fashion?
That's a great question. I think that there's a lot of really valuable free online resources available to interested clinicians that provide a very good categorization in terms of the available evidence for applying a genetic result to patient care. And the one that I really recommend clinicians who are interested in pharmacogenetics become familiar with is the Clinical Pharmacogenetics Implementation Consortium, or CPIC. This is a multidisciplinary group that publishes clinical practice guidelines to educate on how the genetic result actually interacts with the medication, but also then provides specific recommendations of how to alter therapy based on a patient's genetic result. Another really great resource for those who are interested in learning more about pharmacogenetics is the Pharmacogenomics knowledge base. This is also a free online resource, and this website states all of the available primary literature, existing guideline recommendations, as well as drug labeling recommendations for pharmacogenetic associations for all approved medications. And so even if a medication or a gene result didn't have a specific CPIC guideline, you could find more information about what the current evidence is for that drug gene pair on the pharmacogenomics knowledge base. There's also quite a few online training resources that are available through different professional organizations or clinical groups. We developed one here about psychiatry pharmacogenetics education that clinicians can sign up for to learn more about the basics of genetics and interpreting results.
Great, thank you. I want to add on to that. I have to say I was actually just in the PharmGKB website this week, and I was really impressed with changes that have been made just over the last couple months. One of the, I think, most important changes they made that I had not really realized was the fact that if you put a drug in, there is a link there that you can use to be directly brought back to where in the package insert, the FDA package insert, the information is around pharmacogenomics. I think one of the challenges that providers, especially those that are not in academic medical center space, is understanding where that information is, because it is very inconsistent from package insert to package insert. Having that ability to quickly find that information is really important. And I think this also speaks to one of the articles that we published in April of 2019 in Savvy Psychopharmacology called Pharmacogenomic Testing. What does the FDA say? And this was where the FDA created a bit of confusion within the field, partly because they announced that they had a partnership with a direct-to-consumer testing company to provide information. And then literally the next day, they had another report saying that any provider that was using this in practice really needed to refer back to the package insert when making therapeutic decisions. But given the inconsistency and where that is in the package insert, made it very challenging for providers. So I think that the PharmGKB as well as CPIC are two tremendous resources that we have available to us for anyone that's looking to implement pharmacogenomic testing and practices. So I'm going to then turn my attention to Dr. Ward again and talk about our favorite topic is what is your best advice in figuring out if insurance will cover pharmacogenomic testing?
Yeah, so that is a really tricky question to answer in terms of determining if insurance is going to cover the cost of these tests. For us locally, we're aware of several products that are covered for patients with no out-of-pocket cost if the patient has Medicare or Medicaid, but not Medicare Advantage. So that's those commercially managed Medicare plans. Often to be covered, the patients need to meet certain criteria, like at least one past failed medication trial, and potentially considering, or the prescriber is considering, future use of a medication likely to be impacted by genetic variants. So something like a CYP2D6 or 2C19 substrate like Lexapro. For commercial plans or those Medicare Advantage patients, it's highly likely that the patient will have a copay that can be hundreds of dollars, like typically around $300. Most companies, actually all that I'm aware of, typically have a patient assistance program, and they're quite variable in terms of how they will or how they may support the patient. So I really recommend offering patients a couple options and then providing them with contact information so they can follow up with the company to look into the assistance options.
Great, thank you so much. And this next question then is going to both Dr. Pasternak and Dr. Ward. How would you recommend reporting the pharmacogenetic testing results in the medical record, and why do you feel it's important to have this documentation? And this question is kind of for those people that are in academic medical centers that are maybe working with testing providers that are outside their kind of internal resources. And so what would you say to a provider in answer to that question?
I think that it's very important when reporting a pharmacogenetic result to report both the patient's genotype from the laboratory as well as their phenotype that's reported by the laboratory in the medical record. And the reason for this is that although many of these testing panels are guided towards providing recommendations for psychotropic medications, many of the genes that are being tested for on these panels are drug metabolizing enzymes or transporters that are not specific to psychotropic medications, and they may impact many other medications prescribed by outside providers for these patients. So by documenting both the genotype and the phenotype in the patient's medication record, you can increase the transparency of the result if the patient goes to another provider or another institution by sharing that information. And by having this information reported in this format, these results can then be applied to other medication decisions. If you're only reporting the potentially recommended medications from a laboratory report, you can really limit the amount of benefit patients could receive from having this data available to them, because this information couldn't be applied to other medication decisions.
Yeah, I think that's a really great response. And I'd only add a couple things to that. The first is that these results are often returned from labs on kind of an external website, but you can get them in PDFs. So I'd encourage you to grab that PDF and upload it to the electronic health record so it's there in some form. We were noticing that when these commercial lab tests were being ordered initially, there were a lot of missed opportunities to get the results into the chart at all. I think about 30 to 40% of our patients over a couple-year period early on didn't have their results in the electronic health record. And then on top of that, I'd also think about the variants associated with potentially serious adverse drug events. So many of these psych panels test for variants in the human leukocyte antigen gene, so the HLA-A and B. And if you're a carrier, you're much more likely to have potentially serious drug reactions to carbamazepine, especially. So what we do is when we have someone who is a carrier of one of these variants, as a safety precaution, we add carbamazepine to the patient's drug allergy list and then describe why.
Kristen, I'm going to follow up with you on that because I know that oftentimes when these panels are ordered for primarily the treatment of depression, there are some different companies that have proprietary algorithms or they use pharmacodynamic variants. I'm thinking about the serotonin transporter, chol-methyltransferase. Serotonin transporter is also known as SLC6A4. So they have these variants that are really disease or I guess antidepressant response specific. Does that mean, is that a kind of a red flag that people can't use them if the medication is being used for a different indication, or do we just not have the data related to that?
Yeah, so just to confirm I'm thinking about this correctly, for the pharmacodynamic variants, the question is, what should others think about related to these results?
It's more around, since if a panel is ordered because someone is being treated with an antidepressant for depression, but then they might also be using an antidepressant for anti-anxiety reasons, how would you use this information, or should you just use caution this information when you're using it for decisions beyond depression?
Oh, great question. I see what you're saying a little better. Thank you. So for that, I state that there's the amount of data showing associations between these like serotonin receptor and transporter variants and medication outcomes often isn't associated with a huge effect size, but sometimes if you're a carrier of certain variants in the serotonin receptor, for example, there's been some association with increased risk of antidepressant side effects for typically SSRIs. So you could use them if you're thinking about using an SSRI for a different indication, but I wouldn't necessarily give it a lot of weight in your treatment considerations.
Thanks. So I think the moral of that story then is you need to understand what is on the panel as well as what is some of the evidence regarding its inclusion on that panel and what you should and can actually do with that information. And I think that gets to our next question, which is also for you, regarding many different labs offer pharmacogenomic testing. And so what do you kind of think about when you're selecting a test for a patient? Or do you just work with one provider and that's the one that you work with?
Yeah, there are so many different ways to think about this question. So I think in an ideal world, it would be a really careful decision about what the lab tests, the patient's background, because different companies test different variants. So if there's a variant that's rare in Caucasian populations, but more common in Asian populations, and you have an Asian patient, you might want to prioritize that panel over another. Another thing to think about is degree of concomitant medication use, because some panels test for more variants that are applicable to non-psychotropic medications. But at the end of the day, the decision oftentimes comes down to what the providers are familiar with and what is most affordable. The one thing I would suggest, though, from a safety perspective, is that if you have a patient who you think may, for any reason, be put on, say, carbamazepine or oxcarbazepine, to get a panel that tests for the HLA-A and HLA-B variants associated with adverse side effects to those mood stabilizers.
Great, thank you. I know that there was a really nice study done by a group in Calgary that looked at some of the different panels and differences in terms of the interpretation as well as the recommendations. And so I would also recommend, if people were really curious about that, to take a look at that research article, because it was not always 100% agreement between them. And I think we've seen that in other areas too, in terms of how that can occur. And so I think I'm gonna go to our last question for this Psychcast, and this is for Dr. Pasternak. What are you working on in terms at Michigan Medicine and the University of Michigan in terms of implementation?
So our focus at Michigan Medicine so far has really been on ensuring that the available pharmacogenetic test results are in the medical record. And so Dr. Ward has worked on some really great strategies in terms of being able to categorize even PDF documents that we've scanned into the medical record. But ultimately, we're working towards trying to be able to provide real-time recommendations at the point of prescribing, so that when a patient has an available genetic result, we're able to provide recommendations to their clinician to let them know that they have a genetic test result that may result in a need to modify their therapy, and really trying to build that into our workflows rather than having to try to have our clinicians remember to go search for these types of results when they're making prescribing decisions.
Great, thank you. I lied when I said one last question. That was our last question. I do have one more thing that we haven't necessarily talked about, and that is informed consent with the testing. And so at Michigan Medicine, as well as others, oftentimes that informed consent process usually happens by the companies themselves that are doing the testing, but I know that some places are implementing an informed consent process themselves. And so I just wanted to bring that up as a topic that might be important to our readership, as well as to anyone who might be listening to this Psychcast, because you are getting potentially some sensitive information based on whatever the testing is that you are ordering or trying to get. So do either of you have comments about the informed consent process, or anything that listeners might want to consider when they're looking at different testing companies?
I would really recommend checking your local guidance or requirements around informed consent for genetic testing. Different states have different requirements, and so you may need to do additional steps based on those state requirements as well.
Great, thank you. And with that, I want to thank both of you for your time today, as well as your expertise and your leadership that we are fortunate to have here at the University of Michigan. I know we covered a lot of information regarding pharmacogenomic implementation, and even though I feel like we covered a lot, I know we're just scratching the surface on this topic. And so if you're interested, anyone listening is interested in reading a little bit more or having some additional resources regarding this, please make sure to check out the column in Current Psychiatry, the Savvy Psychopharmacology column, because we do try to cover this topic, and anytime anything new happens, we try to be very nimble and make sure that we're covering that within that column so that the readership can stay really informed on this topic. And so once again, I want to thank both of my panelists today for answering our questions, and I want to thank everyone who has listened into this podcast.